Good morning. My name is Patrick Mudharia from the School of Health Sciences, and you're welcome. Thank you. In the interest of time, I hope everyone has a copy of the program. Even if it is a soft copy, there's a copy that had been sent, so that we can have our presenters ready in the order of the program. So we have the first presentation that will be done by Pauline. The co-authors are Peter Ntoiti and Mary Joy Kaimuri. The second one will be done by Mirore Munyere, Eric Pamelin Mutunga, and Tranera. Then we'll have the third one by Kabuku, Kubai, Mburugu, and also Duranira. Then we'll have the fourth presentation, which is on climate change and agrochemical use trends. That is being done by Kirongo David, Patrick Kubai, Jenduto, and Duranira ST. Hello. Oh, presentation. Our dear presenters, there's a message that has just come in, so that we have all the presentations from a central place. Kindly forward your presentation to the email that is being typed there on the smart board. Kindly send your presentations there so that we have them in a central place. So the first paper, that is on assessment of healthcare professional skills in pain management in Meru Teaching and Referral Hospital and St. Teresa Hospital, Kerua. The presenter can be getting ready. So the first presenter, maybe you can come forward probably with your laptop, so that the others from the second presenter, they can be sending their presentations here in the interest of time. So the other presenters can be sending their presentations. Yeah? Okay. Let us please get in and so that we can continue with this session. Those who are outside, kindly let's settle in. Those who are outside, please, let's get in. Thank you. I'd like to acknowledge one of us who has just come in. Kindly introduce yourself.
Good morning. A pleasure to be with you. Welcome. I'm Dr. Miriam Matu, a lecturer in the Department of Clinical Medicine, School of Health Sciences. Thank you. You are the chair. Tuliambiwa ndio chair. Endelea tu. Endelea, please continue. I will take over. Okay. Now that you already started. Okay. Sawa. I will take over.
Okay. Thank you. Thank you. May the other presenters also send their presentations there so that we can present uninterruptedly. So every presenter has 15 minutes, and I think if you're ready, we may start. Thank you.
One, two, check. Good morning once again. The butterflies cannot miss. My name is Pauline Trufena Wanzala, MSc Nursing student. I'm being guided by Dr. Peter Kailemia and Dr. Mary Joy Kaimuri. Today I present a topic. In the booklet is assessment of healthcare professional skills. Change of topic slightly. Typology and healthcare professionals' competency in pain management in Meru Teaching and Referral Hospital. Now, what is pain? It's actually just an unpleasant sensory and emotional experience, typically caused by or resembling that caused by actual or potential injury, tissue injury. Then it is caused either by tissue or nerve damage, or it can also be due to psychological factors. When you have pain, it affects, it's a global human health concern, universally human experiences, and affecting all races. So statistically, chronic pain affects 30%. 30% of the world's population actually suffer from chronic pain. 50 to 80% hospitalizations in the UK have been reported. Then 70% in emergency department in the US. And also, it requires, pain management is a human right and depends on the clinician's competency. So adequate knowledge of pain assessment and management is very paramount for effective pain management. This pain management also requires a multidisciplinary and multimodal approach. Globally, it affects billions of people, that's 30%, converting 1 in every 5 patients that we meet every day will suffer from pain. 20% has been reported in developed countries, about 13 to 51% in developing countries, 83% in sub-Saharan Africa, and in Meru, a survey that was done amongst members, 61% of them were experiencing pain. So effective pain management components will require a close follow-up of pain management guidelines. It requires trained healthcare professionals and adequate facilities. And effective pain, when pain is managed effectively, the outcome is quick patient recovery, comfort for the patient, and overall quality of life. So healthcare professionals must demonstrate good competency in pain management. But worldwide, healthcare professionals have demonstrated varying competencies when it comes. Like in Kenya, Kericho County, 91% of clinicians had inadequate knowledge on pain management. And at MTRH, between September to November 2023, 30 files were sampled randomly. None of them, actually all of them lacked the documentation on effective pain management. So the objective, the broad one, is to assess the skills in pain management among healthcare professionals at Meru Teaching and Referral Hospital and St. Teresa Mission Hospital, Kirua. The specific objective was to tabulate the types of pain assessed and managed by healthcare professionals, and the second objective is to describe the healthcare professional skills in pain management in Meru Teaching and Referral Hospital. So my research questions were, what type of pain is assessed by healthcare professionals at Meru Teaching and Referral Hospital, And how do healthcare professionals apply pain management strategies? The significance of this study to the researcher is to enhance researcher skills and become a source of reference for future researchers. To practice, the results are potential for use to improve pain management in these two facilities and Meru County at large. And to policies, education programs on pain management is paramount, and formation of pain management teams will be very key. Justification: so many studies have been done in developed countries and very few in developing countries, Kenya being one of them. None has delved explicitly to describing the healthcare professional skills in pain management. So my assumption was that participants were involved had basic training in respective cadres and same level of patient care in both hospitals. Limitations: inadequate sample size due to strict working schedules, and the limitations is HCPs on duty of sound mind and at the outpatient accident and emergency medical and surgical wards in Meru Teaching and Referral Hospital and St. Teresa Mission Hospital. Methodology is, the study design is a cross-sectional study design carried out between March to May 2025. Study site is Meru Teaching and Referral Hospital and St. Teresa's Mission Hospital. The study population is 494 healthcare providers, including doctors, clinical officers, and nurses at Meru Teaching and Referral Hospital, and then the patient files. The study sample was calculated using Fisher's test. A total of 140 healthcare professionals were, the number was calculated, that is 22 doctors, 33 clinical officers, and 1 or 2 nurses. Owing to 10% attrition, it gave me a total of 140. And then 30% of the total of the participants, that was 48 patient files. Inclusion criteria is healthcare professionals in medical, surgical ward, accident and emergency, and outpatient. Exclusion criteria is any participant that would be very sick or mentally incapacitated. Sampling criteria use convenient sampling for the 2 hospitals, stratified sampling for healthcare professionals, and simple random sampling to select the participants. Then systematic random sampling to select the patient files. The research instrument was a self-administered questionnaire adapted from Ferrell and McCaffrey, 1987. And then the pre-testing was done at Consolata Mission Hospital. Ethical consideration was Meru University Research and Ethics Research Committee, NACOSTI, Meru Research Center, Research Office, Meru County Research Office, and Meru Teaching and Referral Hospital and St. Teresa Hospital Administration for approval. A written consent was sought from all the participants, and confidentiality was maintained. Data collection, it was a self-administered questionnaire and a checklist for documented information, and numerical data was collected. Data analysis, data was cleaned, entered, and coded into SPSS version 29, and descriptive statistics, frequencies, and percentages were also used to analyze the data. Associations of the data were done using the binary logistic regressions and inferential statistics such as chi-square and ANOVA, and correlations to determine the significant relations of the results at 95% confidence. So the regression was also actually done to predict the practice of healthcare professionals versus individual characteristics. Here are the results: the demographic information, the data setting, the age, gender, designation, education level, work experience, working area, and pain. Pain management costs attendance. So the types of pain assessed and managed by healthcare providers at Meru Teaching and Referral Hospital. The common was neuropathic pain, inflammatory, acute and chronic pain are the most common types assessed and managed by healthcare professionals. This could be owing to the knowledge to be able to identify the complexity of the pain. So as assessed by every designation, we can see that neuropathic pain was assessed by 83% of the doctors. I'll go for the majority. Inflammatory pain was assessed by still 83% of the doctors. Among those who assessed neuropathic pain, actually, let me just go through the totals, that those ones that assessed each kind of pain. You're seeing that neuropathic pain was assessed by 71.9% of the participants. Inflammatory pain has been assessed and managed by 74.1%. Acute pain by 75%. Chronic pain by 75.6%. Nociceptive pain was actually managed by less than half of the participants. That's the number is 62. This is owing to the complexity of the identification of this type of pain, because the pain could be because of different reasons. And so even the functional pain was also assessed by a third of the sample population. When we talk about the skills in pain management, the questionnaire had 21 categorical questions that was under the 4 themes, concentrating on healthcare providers' practice, and sub-scores. It was summed up in those categories. It depended on the knowledge, on the use of assessment skills, availability of the pain assessment skills, and collaborative decision making. So the sub-scores that I categorized this was the clinical knowledge and the collaborative skills in pain management. We can see, just a minute, on this graph, we can see that the most common used type of scale is the numeric rating scale, which is very simple and easy to use when assessing pain, which was actually used by many, about 85.9%. But we're looking at pain assessment checklist for seniors, the last one, for seniors with inability to communicate, those ones who have cognitive issues. We can only see that it was only used by 0.7%. So they charged on how frequent the healthcare providers use these assessment scales. We can see that 56 out of 135 actually used the pain assessment, always used the pain assessment. Still, we have a bigger number that do not use the pain assessment scales. And that one raises our question on the effectiveness of pain management within these 2 institutions. Using the pain assessment scale by designation, we can see that 5 doctors out of 18, 16 doctors out of 30, and 35 nurses out of 102 always use the pain assessment scale. And that one also still gives us a question. So I also did an ANOVA, analysis of variance, because the questions were many, so we did the mean of these questions. And so the F statistic that was calculated was the ratio of the means, resulting at 0.820. The significance level for this F statistic is 0.443, greater than the conventional alpha of 0.5. This means that amongst all the cadres within the health facility, actually, just by designation, there is no difference in the way they manage the pain they manage pain for patients. That is the doctors, clinical officers, and nurses. And then we did a relationship between course attendance and total skills. So the results were highly significant because it combined the education, the attending pain management course, and now the designation. So the results were highly significant. We are seeing a Pearson of 8.197, suggesting a relationship between course attendance and skill and other specific determinants of pain management. Then we also did the correlation studies for knowledge and skills. The relationship was also statistically significant, giving us a p-value of less than 0.01. So the Spearman relations was 0.05, confirming that positively pain can be influenced by attending a course management pain. Then we did a regression model to assess if actually increasing your knowledge through training could affect the skills, and ANOVA was used to test the significance of this model. And so it tells us that the sum of the squares 999 with the degrees of freedom 3 and residual error sum of the squares, this F statistics at significant level 00 is highly significant to say that even the regression model that we created still confirms that attending a pain management course increases somebody's skills in pain management. And then the coefficients.
2 minutes, Pauline.
Thank you. For total scores in pain, predicted by the total knowledge, it says that majority of these questions as we asked, that is 17 out of 19, were actually answered correctly. So knowledge affects. But those were questions answered depending by the healthcare providers. The questions rise on the checklist that we did to audit the documentation and to validate the results of what they have said. 48 files, 10 checkpoints, and 24 files from each facility. We can see that all patients' files reviewed had identification details, diagnosis, and pain management description was well documented. Detailed pain documentation was lacking. Only 22% included pain classification, just 4.2 recorded findings from a pain management assessment scales. And the differences were observed among healthcare providers at Meru Teaching and Referral Hospital and St. Teresa Mission Hospital in documenting, considering the pain classification, timing, and communication about pain. So healthcare professionals demonstrated good knowledge in pain management, poor documentation practices, limiting their effectiveness and overall competency in pain management. This neuropathic pain, because it was assessed and managed by majority, this agrees with the systematic review of epidemiological studies that 6 to 10% prevalence of neuropathic pain exists. And participants' use of pain assessment tools, we can see that in Vietnam, 44% never or rarely used, just as what we have seen in this study. Then the accuracy of pain management and pain assessment and management is an important indicator for monitoring the quality of healthcare in our hospitals. So this study has found that pain assessment documentation is lacking, raising a question on pain management skills. Worldwide, healthcare professionals have shown varied competencies in pain assessment and management, concurring with the findings of this study that has identified. And I conclude by saying that majority have assessed and managed at least more than one type of pain, indicating their ability to identify. But inconsistencies in how healthcare professionals use pain assessments tools also exist. Although most follow pain management guidelines, variation in pain management application skills by designation, work area, and attendance exist. So there is a proof of a gap in evidence-based practice regarding to pain management. So because few regularly use or document pain assessment findings, this highlights the need to improve the knowledge and skills in pain management at Meru Teaching and Referral Hospital and St. Teresa Mission Hospital, Kirwa. So there is need for formation of a quality improvement teams to guide and audit management practices related to pain at Meru Teaching and Referral Hospital. That is my presentation. Thank you.
Thank you so much. Let's give her a round of applause. That was a wonderful presentation, Pauline. Yes, we'll just take 2 questions in the interest of time. But before then, kindly let me invite our Dean to say hi and probably introduce also our guest. Dean, welcome.
Good morning. First and foremost is to thank all of you, especially our guests who have come from far, the Kenya Medical Training College students who will be joining us here every day. For the next 3 days, we will be having a group of 50. So send our regards to Mr. Njagi, Samuel Njagi, and the management of Kenya Medical Training College, our postgraduate student, all the way from doctoral student to master's student and even undergraduate. For the first time, we are having one of the graduate students presenting research findings, and this is a great honor. To the faculty members of School of Biosciences and School of Nursing, thank you. We need this place to be full all the time, so please mobilize all other members to be here. With me, I want to recognize the guests who are with us from Meru County government, and our keynote speaker who will be talking to us tomorrow. He has a lot of new knowledge and new things all the way from the University of Texas, and I welcome him to say hi. And he has nodded into me that he is so much interested in your study.
Thank you.
So already you have a partner.
Thank you.
He will be working with you and your supervisors. So please, after presentation, make sure you say something to him. So Prof. Goodman and the members from the county, please, you can come and say just one word. The county and government officers who are here. Meru County. There's nobody from Meru County. Okay, Prof. Goodman.
Good afternoon. I am an associate professor at the University of Texas Medical Branch in Galveston, Texas, and also the executive director of a nonprofit NGO working here in Meru County. We've been here for 13 years. So I have friends from Sodzo, Kenya. Thank you for coming with me. I look forward to speaking tomorrow about the work that we've been doing. The work that you guys have been doing and are dreaming of doing is inspiring and amazing. Speaking on behalf of faculty at the University of Texas Medical Branch, what you guys are doing here at MUST gives us a very attractive set of collaborators, potential collaborators, places to dream with and partner with, and hopefully go far together. So thank you for hosting me. Thank you for this great presentation. We look forward to the rest of the day and tomorrow.
Thank you, Prof. Yesterday we had 7 of them here, no, 5 of them. We had a long meeting, and they are looking to collaborate with each and every member of the faculty and even our partners from KMTC. So please, we will be calling for another meeting. We'll be inviting you for more meetings. They want to have specific MOUs with different departments in our school. So Dr. Sakayo, I hope you are here. There's a team already which is working with Professor Raja, and there is also a team which is working on physical medicine with Joseph Rogers. We have a team of many people from University of Texas who want to work with our students and faculty. So please be alert when we call you so that you can proceed. Gitare, you can say one word as a representative of one of our partners. We will be posting our students for community health attachment to this group. They are partners in our school, and I wouldn't want them to leave here without saying something. So Gitare is the director, Sonso Kenya, and he works with us also.
Okay, thank you very much. Good afternoon. Yeah, my name is Stanley Gitare, country director, Sonso Kenya. I think I'm very excited with our partnership with the MUST. This year, I think last month, we started the attachment. We already have 3 students working with our program. And I'm sure they are gaining a lot of experience. So we look forward for more areas to partner with the MUST. Thank you.
Thank you. We'll continue deliberating and talking. Please, thank you, Chair, for allowing us to say one word. My name is, I said, Dr. Patrick Kinyo Kubai.
Thank you so much, Dean. All our guests feel at home. All right, now back to Pauline. Was there anyone who had a question? All right, if none, thank you so much, Pauline, for that wonderful presentation.
Thank you.
Yes. So now we move on to the second presenter. And remember, all the presenters, kindly share your presentations to the email written there on the smart board. Yes? Yeah, that isn't it.
I don't think he's the one. Because there's supposed to be somebody from the Nairobi. So kindly
Yeah, let's follow the data.
inform them that we follow the own
Exactly.
so that we can present.
Yeah, sure. Yes, kindly, let's adhere to the program. So, after assessment of healthcare's professional pain that was done by Pauline, the second presentation is on the unseen burden of tinea capitis infection in primary school going children in Tigania West. And then, so who's presenting that one? You are the one. Is your presentation already sent in the email? All right. Come forward kindly so that we don't have a lot of time. Yeah. So we reduced the presentation time from 15 to 12 because time is not on our side. Then after him, we'll have examining the link between malnutrition and quality in chemotherapy patients in MTRH by Kabuku, Kubai, Mburugu, and Thuranira. So kindly make sure your presentation is also loaded. Yeah, because of time, ladies and gentlemen, is yours already there? Yeah. She can come. Yeah, just come forward. Just come forward. Murari, you're not sent yours. Okay. Yeah, just come because of time. So we only have those 6 presentations so far. Okay, let's start.
Good afternoon, everyone. My name is Lilian Kabuku. I'm a master student in public health, and I'm humbled to be here this afternoon. And without wasting any time, I'll go directly to my presentation. And first, I want to appreciate my supervisors, Patrick Kubai, Mburugu in absentia, and Ranira. And the topic is examining the link between malnutrition and quality of life of chemotherapy patients in Meru Teaching and Referral Hospital. And I tried to follow the rules of MUSTIC presentation. So coming up with 10 slides out of our 120 document was a challenge, but I'll manage. We all know what cancer is. It's the abnormal growth of cells in the body, which later destroys the body tissues. And globally, malnutrition affects 20 to 70 of cancer patients. And in Kenya, the cases are quite enormous. That is, in 2012, we had 7,000 cancer patients, and our mortality, which increased by 16%. And in Meru County is among the top counties in Kenya with a high burden in cancer cases. And as during the research and during the data collection, the major problem that came up is the issues to do with reliable data on the quality of life and the nutrition status of cancer patients. And to the objectives and research questions, the main or general objective is to assess the nutrition status and quality of life of cancer patients on chemotherapy at Meru Teaching and Referral Hospital. And to the specific objectives, we assessed the nutrition status of the cancer patients. we determined the management practices of nutrition impact symptoms. Nutrition impact symptoms are the symptoms or the effects that come after the patient is initiated on chemotherapy. And we also assessed the quality of life of these patients. The significance of this research, or this study, will be of relevance to the clinicians on improvement of cancer care and the outcome of patients. To digress a bit, I had recently 2 cases of cancer patients who had very stable nutrition status, but immediately after being commenced on chemotherapy, they deteriorated, and 3 months down the line, they were nowhere to be found. They had died. It will be of relevant also to public health, that is in addressing global and national concerns around nutrition status of cancer patients and chemotherapy. It will also advise on policy and research in formulation of policies and research guidelines on issues to do with cancer, malnutrition, and quality of life. And also, it will help you, me, and other researchers in coming up with more information or wanting to know more information about the cancer, nutrition status, and quality of life. The literature review, we collected a lot of data. We had a lot of information from different scholars, and a summary is that malnutrition affects 10 to 20% of cancer deaths. It causes 10 to 20% of cancer deaths. And the common nutrition impact symptoms that came up during the literature review were nausea, vomiting, appetite loss, swallowing difficulties, fatigue, taste changes, among others. Chemotherapy also increases the risk of nutrient malabsorption. Remember that in treatment of cancer, diet is very key. And also quality of life of patients strongly influenced by malnutrition, was strongly influenced by malnutrition, which encompasses physical, emotional, and social well-being of individuals. We did a descriptive cross-sectional study, and the setting was at Meru Teaching and Referral Hospital. The sample size was of 246 patients, of which we used the Sloven's formula, and the sampling was, we used a convenience sampling. The tools, among others, are Nutrition Risk Score and World Health Organization Quality of Life Brief. Data collection and analysis. The data was collected using Nutrition Risk Score, the questionnaires to collect demographic data and symptoms, that is the nutrition impact symptoms. The World Health Organization Quality of Life Brief, we used it to collect the physical, the psychological, and social, and also environmental, that is data on quality of life. And the data was analyzed using descriptive statistics, the t-test frequency, Pearson's correlations, and also the data visualized via graphs and tables. The key findings include, after carrying out the nutrition assessment on patients that were on chemotherapy, we had patients with a BMI of 36%, which was 36% of the patients were underweight, 42% were normal, and 22% were obese. And our nutrition risk score, moderate, 76% of the clients or the respondents had moderate, were moderately, or they had moderate to high risk in malnutrition. Then the common impact, nutrition impact symptoms included appetite loss, which had 45.8%, nausea and vomiting, 35.2%, and swallowing difficulties, 20.3%, and others, and a lower score. Also, we had a quality of life ratings, of which 10% of the respondents had very poor quality of life. And we said this very poor, with this quality of life is defined across different abilities in a person's life. So 10% and very poor quality of life, then 25.8% poor, then 64% did not know really whether they were good or not. And the domains affecting physically, different people in pain, fatigue, anxiety, depression, isolation, stigma, and also others, most of them saying that the cost of cancer treatment and a lot of high cost. And in correlation and interpretation, underweight and older age, this is the category was associated with lower quality of life. Then the respondents with high risk and low education, they had worse quality of life. And under nutrition impact symptoms, we had reduced food intake and well-being. In conclusion, malnutrition and nutrition impact symptoms significantly reduce the quality of life of cancer patients, specifically on chemotherapy. Recommendations. Clinically, we recommend that routine nutrition screening, personalized data intervention, and dietary intervention, integrated nutrition and integrate nutritionists in oncology teams. So this is very, very key to us as scholars, as healthcare workers. It is very much important to involve the aspect of nutritionists, the aspect of dietary management, the aspect of individualized and personalized treatment for cancer patients, putting into consideration dietary management. Then another recommendation is policy and research. We recommend that further research be conducted in areas to do with nutrition, quality of life, and chemotherapy to advise the healthcare workers and other policymakers on the better management of this patient. Then also importance is awareness and campaigns. The limitations of the study include this study was single site study that is only at Meru Teaching and Referral Hospital, though the pilot study was done at Isiolo General Hospital. Then it was self-reported data and varying chemotherapy stages among patients. Thank you.
Thank you so much. Let's give her a round of applause. Thank you for that wonderful work. Are there any questions? Just two. Yes, please pass the mic.
Thank you very much for the presentation. Perhaps I'd like to clarify, number one, how you define malnutrition in relation to cancer, because it could be either overnutrition, undernutrition, and chemotherapy treatment itself can actually cause malnutrition. So how you dealt with that. Secondly, the quality of life could be dependent on the type of cancers the patient have, but also could be dependent on the type of the chemotherapy itself, because the impact of different cancer drugs have different implications on the nutrition. And then since you're talking about the impact, if you are doing a prospective study where you had a baseline assessment and then you followed the participant over a period of time, so that then you compare the baseline data that you had and then look at their different nutrition within certain times, like 3 months or 4 months, and then look at how that changes while considering the types of cancer and as well as the types of the drug that they're using. Thank you.
Okay, may I respond to the first one? On the definition of malnutrition in this study, malnutrition was defined as undernutrition. It was not overnutrition. The second question was, kindly remind me.
The quality of life is influenced by the type of cancer that the patient is suffering from, as well as the type of drugs that one is using. And both of them have different impacts on the nutrition in terms, like some of them will cause a lot of...
Consider what stage are you commencing that chemotherapy. The uniqueness here is not necessarily what happens after chemotherapy, but can we be considerable? Can we be considerate on what stage are we starting? How is the nutrition status? Can we at times hold on, or can we explore issues to do with dietary management as we commence chemotherapy? Thank you.
Yes, the last one was about if you did a prospective study, and since you are concerned about malnutrition or nutritional status, then what about other potential factors that might influence beyond nutritional status? Because chemotherapy can have impact on other aspects, including even the psychological and emotional aspect. Thank you.
Thank you. I'm advised, and that's why we recommend further research so that other scholars can pick up from where we've left.
Okay, thanks for that informative presentation. But just to follow on his question, on how you defined malnutrition, I've seen obesity, which I think is overnutrition. My concern was, did you stratify that data like first degree obesity, second degree obesity?
It was not stratified because our concern was not necessarily on obesity, it was under nutrition, but we could not overlook a patient who was on chemotherapy, still obese. We had to capture that data.
An assessment of the nutrition, or was it just self-reporting on the patient? Because I saw in your limitation self-reporting. And the other thing was, did you link the nutritional status on and the quality of life and the symptoms? Is there any relationship between the nutritional status and the quality of life that didn't come out clearly? And I also felt convenience method of sampling was a bit limiting. I don't know how it came out, because you may not be able to generalize. And also, following up on this question, a prospective study would give more meaning, because you have the assessment and then you see whether it was actually affected by nutrition, starting chemotherapy. Yeah.
Thank you. As I begin by saying that it was a challenge having 10 slides for this presentation, I hand another slide that had all that information. We used questionnaires to the patients. We did actual nutrition assessment to the patients, and we also looked at the data, their medical history, and also the self-reported. So having all that information in the 10 slides was a bit challenging. About the study, I'm still advised, and I appreciate.
So as he sets up his presentation, kindly remember that we stick to 10 minutes of presentation and 2 questions. So as he does that, kindly allow me to acknowledge the presence of my colleagues, Professor Eric Mushiri, who is in the room, Dr. Samuel Njeru, Dr. Peter Kailemia, who just spoke, and Afaksad Chege, Dr. Ruto, Jane Ruto, and also Javas Mereti, and Dr. Murioki here. Okay, 10 minutes.
Okay.
10 minutes.
So, Antonini Mugo Munyeri. I am a soon-to-be graduate of this wonderful university of Mary University of Science and Technology, and I undertook bachelor's in medical microbiology. So I'm honored, first of all, to stand here in front of all of you, and I want to take you through our study. Our study, we are going through fungal infections, mainly Tinea capitis infection in primary school-going children in Tigania West, Meru County. Imagine a child eager to learn, eager to play, but is put set aside due to relentless itching, painful sores, and the burden that goes with social stigma of having Tinea capitis. That's why we undertook a study on the unseen burden of Tinea capitis in Chiro, Ghana West. So, sorry for that. I don't know what happened to the slides. But we were undertaking Tinea capitis, and Tinea capitis is a scalp ringworm infection that affects children mainly under the age of 15 years. And our main objective, a general objective, was to investigate the prevalence, risk factor, and characterization. Okay, let's go directly to the methodology. So we were able to use a cross-sectional design to primary and Gimpine Primary School. We sought approval from the school and to the individual learning